I'm going to talk about the professional life in PCI. We are always talking about the professional PCI. Why we are talking against the professional life in PCI? We know that when we are going to perform professional PCI, moreover in left main, it requires two things. First, we have to do appropriately, and the second one, we have to master two-stand technique. On the other hand, if you are going to perform upfront two-stand strategy, we have to do upfront strategy appropriately and have to master uh, professional PCI. In this kind of situation, we need to do in every steps properly. That's why I'm talking about how we have a cautious in every step of professional PCI. In the left main, if we are doing appropriate left main PCI, is we can compete with the KPH. But if we are not do that properly, it's going to be fatal complications. So the ultimate goal of bifurcation, PCI is actually to reconstruct natural vessel shape, restore rheology, preserve flow and functions. And EBC recommended professional stenting as the chosen strategy for the majority of bifurcation lesion. And professional left main PCI needs accurate analysis of lesion anatomy and functions, perform essential steps, and optimal result assessment. So look at the EBC, which proposed 5 essential steps for professional stenting. After lesion preparation, you put the stent all the way to at the main vessel, and then doing a POT. And afterward, if you are going to treat the side branch, you have to do kissing balloon properly, and then end up with the finish, or you have to perform two-stand technique at that time when there is a compromise of the side branch. But in doing this, there is numbers of pitfalls. So the first one, prior to starting the 5 steps of the professional stenting technique, it is important to ensure lesion preparation and side branch protections. Look at this case. This is a left main bifurcation case. We plan to perform professional stenting technique. It looks easy, but look at the side branch is not just, it's not so tight stenosis. So that's a, but if you are putting the stent there and the side branch compromise, then it will be very difficult situations. So how do you protect this circumflex? There are three kind how to protect strategy to protect side branch. First, side branch osteal dilatation. The second one occupies the side branch osteum, whether using, well, sorry. So the other strategy is occupy the side branch osteums, whether using a gel wire, gel balloon, or gel corsair, and the the other is debulk the counter side plaque when it is calcified, the opposite of side branch. So at that kind of situations, we predilate the circumflex using Scoreflex TO15. But what happened? It dissected. The circumflex is dissected. Once both branches, you already prepare using the balloon and treat them aggressively and show dissection. A bailout to upfront two-stand strategy is unavoidable. At that point, we use a decay crush technique. So if you are going to perform professional technique, you have to be careful in protect the side branch. So routine side branch osteodilatation is discouraged. If you have to perform it, do it with care. Use proper balloon size and pressure, and lower the threshold to use scoring and cutting balloon to make discrete incision and control malignant dissection. And then third, perform arterial ablation when indicated. In some professional left main bifurcation, we just only two-step and finish. But it requires proper proximal optimization technique. The aim of the POT is to optimize mean vessel stent result, well-opposed and well-expanded stent, and reduce the abdominal rewiring, the risk of abdominal rewiring, expand the stent cell overlying the side branch osteum, and facilitate optimal distal rewiring into side branch, and facilitate to end at the stop 2 of the professional stenting. And how to perform the proper part: use a appropriate size balloon, perfect balloon position, and appropriate balloon expansion technique. Imaging can guide to perform POT. If you are not doing the perform POT well, and then the complication is easy to happen. Look at this these lesions with at the ostial part of the LED. When we plan to cross over stenting from left main LED, this is known as STEMI anterior with a high bleed risk, 71 years old lady. And then after we are using 5.0 non-compliant balloon after crossover stenting from the LED to left main, look at this proximal recrossing point. There is a overlying strut there. This is high bleed risk lady. So we have to remove all the strut there. What we did is we did another report. And then excellent side branch operant happened after proper part. And we can end up these procedures without kissing balloon inflations. So look at this 3D OCT is the open up the ostial side branch. So you can use another pot. Maybe when the first pot is not go just close the carina side. That's why we have to perform proper pot. So when to treat the side branch? Treat the side branch when there is a compromised side branch, slow or no reflow, angiographic tight stenosis, and significant functional tests. And the evolving reasons is, especially in the left main, is approved to prevent pre-stratatory stenosis because overlying of the stratus of the side branch. And the other part is we have to prepare the future interventions. Because sometimes if you are putting the stent of the left main LED, and there is over time there is the plaque in the circumflex become increased, and then very tight stenosis, but you haven't opened up the ostial side branch of circumflex, and then it's quite difficult to treat when it happens. So we already talking about the step 2. But how about when we need to treat the side branch? To treat the side branch, we need to have a good case. That's important. To have a good case, it requires perform the distal rewiring, or perform the rewire at the best strut cell. So how to have a good case? Exclude the abdominal rewiring. It happened 44% in the October sub-study. So accidental abdominal rewiring occurs only in the presence of malapposition and is prominent risk of in bifurcation treatment when rewiring through already implanted stent. And how to avoid abdominal rewiring? Confirm wire route and deep engage of guiding catheter, knuckle wire, pull and redirect the distal main vessel wire and use a double lumen catheter and appropriate POT balloon size and dilatations. Look at this point. This is this case. Sorry. So this is a case that we had abdominal wiring. We already crossover stenting. So followed by pivot and rewiring to L circumflex. But look at this. We use IFOS to detect. After we rewire to the circumflex, we try to detect, we assess whether the wire is go to intrastent and go on the right route. But look at this. The wire goes abdominal side through falls through. So this is the wire goes here. So at that point, we rewire using double lumen catheter and re-evaluate. And when already the wire goes on the true intrastent all the way and go to the distal strut, we can perform the kissing balloon. Sorry. And wide opening of the circumflex. Sorry, I cannot stop here, actually. Oh, I try to... I try to use to... So that's point the circumflex down. It is already on the ostial left mid. How to have a good kiss? Another point that we have to consider is optimal side branch recrossing. So we already know that the wire have to go to the distal strut, but sometimes the distal part is to the right route. There is a link connecting type and guide wire recrossing point at the proximal part. So we reroute to this distal, not the far distal, because this is the connecting link. If you are going here, it's not going to open the strut all the way. So just go not to the far distal, but to this distal cell. And afterward, we can do kissing in this point with no or minimal gel strut and large side branch ostium. In the other point, I'd use proper balloon size using NC balloon and 1-to-1 ratio to the side branch and distal main vessel stand, and proper balloon dilatation. Sometimes we have to do a sequential high pressure balloon dilatations, inflation, and then simultaneous inflation at low pressure, ATM, and exact simultaneous deflations. The last step. Sometimes we already kissing balloon, but we have to be cautious after that. How to escalate the criteria to the stand-to-stand technique? There is many numbers of recommendation using angiography, intravascular imaging, or physiology. Look at this case, which is a very tight stenosis, ostial side LED and ostial circumflex. And there is a calcified ostial LED, and this is ostial circumflex. So when we have to debulk this calcified lesion, so we can put the stent all the way, and then it's not compromise the side branch. And then afterward, we are, sorry. Okay. And then we put a 4O 30 millimeter stand to the left main distal circumflex. But look at the LED. We still have some. There is no not good the ostial LED. So we put another stand. Decided to put to perform TAP using a 3.5 30 millimeter stand. And then when you are doing the two-stand technique and perform POT, stay away the balloon from the carina side. And this is important. If this is the carina, metallic carina, you have to stay away from close to the carina. And this is going to be give you side branch open up. So look at this, and this is the carina, and this is a circumflex, and this is a LED. Exactly carina at the middle part. If you are putting the balloon here and inflate here, the carina go to other side. And last, look before you leave. Sometimes you're already very good in doing all the case. Sorry. And post crossover stenting, left main LED. Look at a very good result. But look at afterward. There is stent deformations at the ostial part of the left main. Despite angiography looks very good, but IFUS demonstrated there is a deform of the stent. Look at this is a deform of the stent. It could happen because of guide catheter collisions. In the October trial is about 40%. It can impact or deform the ostial, the proximal part of the left main stenting. And the 3 years left main related major adverse cardiac event is high if there is a deform of the ostial part, deform of the stent. Stent deformation can happen. The mechanism abdominal wire, forward movement of the guiding catheter after pulling back a partial deflated balloon, IFUS or OCT or the gel wire, and how to avoid, confirm the wiry route, wait for full balloon deflation before retrieve the stent balloon, awareness of guide catheter interaction on device withdrawal, and retrograde traction of guiding catheter to minimize the risk of deformations. How to fix it? Correction by POT, and sometimes we need additional stenting if required. And we corrected the deformed stent by report. And this is the result is a acceptable result. So before you leave, you have to check the stent at the left main. Just don't count on the angiographical result. So the take home is that professional PCI entails multiple steps and can be challenging to perform. Negligence and pitfall if left main professional step can lead to use of two-stent technique or even result in fatal complications. Mind your step in professional left main PCI. Thank you very much.